All right. Welcome, everybody. Are you ready for the first session? Yeah. All right. Excellent. My name is Marina Sirota. I'm a computational faculty at UCSF, also part of CPH, and the acting director of Baker Computational Health Sciences Institute. Our first session is the AI-powered journey, and hopefully we'll tease apart some of that AI for you. And our first presenter is Dr. Ziad Obermeyer, Associate Professor Blue Cross of California Distinguished Professor at UC Berkeley. Thank you.
Thank you, Marina. So I thought maybe the theme is deployment. How do we get algorithms out of places like this and into places where doctors actually apply them to patients? And I thought to make it concrete, I'd actually just share as an example of something that I at least would like deployed, something that I've been working on that I'm very excited about getting into the clinic, and then use that as just a concrete example to fix ideas about what deploying that might look like, and maybe thinking about it a little bit differently than the way people traditionally think about it. So this algorithm starts with what I consider a medical mystery. So this is something I remember learning about in medical school and just being completely floored, which is that every year, and in the US alone, a lot of people just, it's a little nerve-wracking. I guess it's good to know I'm on the clock. Thank you, Daniel. So a lot of people just die with no warning. It's called sudden cardiac death, which is a classic medical thing where, it sounds very precise, but it just means people drop dead and we don't know why. This is very hard to study because by the time you know whom to study, you can't study them anymore. The basic thought is that something causes an arrhythmia that causes the heart to stop beating effectively, and then organs lose blood flow, and then the person dies. And I'll say that if you ask most people in medicine about this, there's a certain lack of curiosity about this incredibly crazy fact that so many people. So, you ask people like, where does this come from? They're like, well, people have heart attacks. And you're like, yeah, but I mean, a lot of these people are perfectly healthy. They don't have high blood pressure. They're like, yeah, sometimes the first heart attack is really big. Anyway, sorry for editorializing about medicine. I think what makes this problem from a policy and clinical point of view even more striking is that we actually have a solution to this problem. We have defibrillators that we could implant in someone's heart. So if we knew that somebody was at sufficiently high risk of dropping dead from a fatal arrhythmia, we would put one of these things in their heart, and it would detect the arrhythmia and shock them out of it. The intuition is a little bit like what happened to my laptop as I was trying to review my slides, which is like it gets into this loop that's unproductive. And so what do? Restart. The problem with this situation is that we're very bad at matching the technology to the patient. And so Exhibit A, lots of people drop dead without a defibrillator. Exhibit B, you can look at those defibrillators that are put into people that are sitting in, attached to someone's heart. And over half of them never fire because the person never has the arrhythmia that we put the defibrillator into the heart to shock them out of. So there are kind of both errors, the overuse and underuse at the same time. What we do is pretty simple. I have a collaboration with a regional health system in Sweden where we get all the ECGs that were done in that region over a multi-year period. Why Sweden? Because we can link everything to everything, and we can link those ECGs to death certificates, and we just predict you had an ECG, what's your likelihood of dropping dead from a cause related to the heart outside of the hospital very suddenly in the next year? And here's how we do. So this is a holdout set of Swedish patients. The algorithm score is on the x-axis. And the way we do it is we just apply a threshold at a certain percentile of risk and look at the rate of sudden cardiac death above that percentile of risk. So if you look at the extreme right of the graph, that top point is like the half a percent of patients. they have about a 10% annual risk. If you set the high risk threshold to identify people that look like the people we enroll in clinical trials of defibrillators, that's about 2% of the sample. Those people have a sudden cardiac death rate of 6% per year. You can compare that to the current state of the art that doctors are using. So this is reduced or low left ventricular ejection fraction. It's a metric derived from cardiac ultrasound. That captures about 2% of the population, and they have a sudden cardiac death rate of 4.4% a year. So we're identifying a group of people that's about as big and that has about the same rate of sudden cardiac death. And very importantly, 81% of our high-risk group does not have a low left ventricular ejection fraction. So this is mostly net new people that we can identify that have a really high risk of dropping dead that we don't currently know about under the current state of the art. Of course, just because you can predict death doesn't mean you can prevent death. So there's a couple of strands of evidence we can piece together. One is we can look at the incidence of those actual arrhythmias on the off chance that they're captured by doctors on an ECG. So these are the rhythms that often lead to the heart stopping, but sometimes they are transient and they resolve. And that goes up in predicted risk. And in that high risk group, in addition to the 6% that drop dead, an additional 3.5% have those rhythms recorded. And that's true in Sweden, but it's also true when we take the algorithm on a trip around the world. We take it out of Sweden and we drop it into a health system in San Diego. And there it also predicts these rhythms. And we also take it to Taiwan, where we can apply it to this very detailed population that has a careful medical evaluation of the cause of death, where it's able to distinguish arrhythmic deaths from non-arrhythmic deaths and from controls who are normal, just based on the ECG, with no retraining or fine-tuning or anything. So this is just one shot, take it out of Sweden and apply it in these other places, and it works well. And maybe, again, circumstantial evidence, but if you look at the Swedish patients who look really high risk to us, but who have a defibrillator, those people die a lot less than they're predicted to based on the ECG. So evidence on some level that these deaths are not just predictable, but also preventable. Okay, so now let's say you believe this and you want to think about, let's get this out of the research world, off that hard drive in Sweden and into the clinic. How do we think about doing that today? Well, speaking from a wealth of painful personal experience, first you figure out this mess of what the hospital's data system looks like. You figure out how to link the electrocardiograms into the Epic or Cerner or whatever they're using. You map out the insanity of where the data are stored and what's 24 hours old and what's real time. It's very, very painful. And I think anyone who's even thought about doing this can attest to that. But then your job is not over, because then you also need to figure out how to get that in front of a physician. And basically, in the current state of the art, there are two options. One option is to make the doctor's life miserable until they, you try to get them to do what you want. So they're trying to do X, and you interrupt whatever they're doing with this Windows 95 style pop-up that forces you to do something. And doctors are, over the years, we've learned a lot about how to get rid of these alerts without doing what the bureaucrats want us to do. And it's very possible, but it doesn't engender a lot of goodwill. And it certainly doesn't result in them doing. So that's one option. Option two is you bury the information in a corner of the screen where nobody ever sees it. So there's nothing in between. There's either incredibly annoying or completely ignored. So here's a different way to think about deployment. And I think this relies on the fact that this algorithm, and I think the one that Adam's going to talk to you about as well, it's not really in the electronic medical record. It runs on images. So the only thing this algorithm learns from is the waveform. We don't even use age or set. It's literally just the waveform. But that actually raises a really useful question, which is why do we need the electronic medical record? So this could be put on a machine and it can just run in parallel. In fact, there's a lot of things that you can do with this that don't involve being stuck with the the big companies that make the machines and that are equally intransigent and annoying as Epic, for the following reason. It's because if you just type into Google ECG machine and you click the shopping tab, you're going to find a number of interesting things. So you can get an ECG machine yourselves for $600. If you want the nice one, this is I think a very nice one. This one's like $9.99, which this has a lot of 5-star reviews on Google. But you can also even get a handheld device. I should have brought mine. So this, you just put 2 fingers on electrodes. This connects to your phone via Bluetooth, and it generates like a pretty nice ECG waveform. So this opens up a ton of new possibilities. And I think the one thing I want to leave you with is that the way people are currently thinking about deployment is very narrow. And it's basically like, how do we get a payer or a provider to do this? And I think that is just fundamentally a dead end. Not that it will never work, like it'll work. And in fact, people have gotten it to work, and you can lobby to get a CPT code, and you can so it can work. But fundamentally, you're trying to make a very small incremental change in a system where there is broad consensus that everything is completely messed up. And so I think that another way to think about deployment that's very complementary to the way that people are currently thinking about it is, we have this technology. We have a patient that wants the technology and would benefit from the technology. Why are we stuck with this set of bad, misaligned intermediaries that are preventing us from matching the patient to the technology? So you can think about actually just building these algorithms onto diagnostic devices, onto therapeutic devices, drug device combinations, building on the fact that there are wearables. And you can also rely on the fact that patients are now paying out of pocket for a lot of things in their own health. So I think expanding that space of deployment options is a really useful thing to do for us and for patients.
Thank you. Next, we're going to hear from Dr. Adam Yala, who is an assistant professor at CPH, and let's welcome him.
Cool. Thank you all for coming. So today I'll be telling a little bit about our work to personalize cancer care, and to kind of set the stage, let's change slides. From a big picture, a lot of what I think about is how can we use everything that we know about a patient to make care meaningfully better? And it is really jarring. Time's on. It's all good. It's all good. So one thing that's special about the setup is that cancer is one of the most information-rich areas of care. You have like gigabytes and gigabytes of data per person. You have many images over time because stakes are so high. You have pathology. You have all of this context. And that offers an opportunity to use all of that to try to make our choice of interventions better. So the kind of shaper problem I often think about is, given everything that we know at a particular point in time, how do we pick between our interventions? And to give a motivating problem to this, I'm going to talk a little bit about cancer screening. So I work a lot in breast cancer, including others. And by and large, I tell people to do the exact same thing, right? Like you're 40 or 50, depending on the guideline. You might be very different in your inherent risk profile, but we'll tell you, get a mammogram every year. And that's just it. The problem with this, and this is kind of the problem with every kind of one-size-fits-all screening guideline, is you have these kind of like dual challenges. On one hand, you have a lot of people adhering to annual mammography who will still get relatively advanced aggressive cancer. And if only we knew, this actually like echoes Ziad's talk, if you only had that foresight, we think we have technology to help with this. There's really exciting trials in Europe showing if you give the right people MRI before this, then we think we can both reduce the rate of interval cancer and advanced cancer accordingly. So if only we had that foresight, we could have reduced that harm and made the screening more effective. At the same time, we have the opposite challenge. Many people, and this is a much bigger number by volume, only have harm through the screening process. Even if there's no unneeded biopsy and it's just maybe you have something, that in itself causes a lot of anxiety, then people might not come back at all. There's a lot of harm associated with this general screening process. And if only we knew, we could do a whole lot less and do better for these patients as well. Now, the good news is that there's answer here is very simple, right? Like you need to do 2 things. We need to kind of get that only we knew. We need to get that foresight. That in itself is a core computational problem. In the community, we call that predicting cancer risk. then we need to do something about it, right? We need to act on that and actually translate it into the world and prove that it works. And so my group focuses on both of those things. And for the purpose of this panel, kind of going in from discovery to deployment, so I'll kind of talk about that in that lens. So I'll start off with this kind of like the prediction side of this equation. How do we get that foresight? Now, this is not a new question. People thought about it since like the 60s and then into the 80s and then until now. And the thing we've landed on, what we actually do both in the US but globally, is we look at a couple bits. So I would ask someone like, what's your age? Do you have any family history? We might use breast density, which is from the image. And that's like now federally mandated. Then you predict like things and you have national guidelines based off this that drive care. The problem with that is that it sucks. So putting that in numerical terms is like we call roughly 15% of the population high risk by this, which is more than we could actually support with MRI, but whatever. Of that 15%, this actually will flag less than a quarter of all the future cancers as high risk. So the vast majority of people going to get cancer will never benefit from these kind of high risk interventions. And the vast majority of people who call high risk will also not get anything. So your sensitivity is low and your specificity is also really bad. So kind of putting back this lens of like, we don't have bits, we have gigabytes. So we have quite a bit more. What can we do about that? That was sorry, it's like a lot of button clicks. A key focus of my prior work and things we're still doing in the lab now, and to kind of zoom out. If you take like just one step, a very low-hanging fruit, we have all this regular imaging. Now we're in megabytes, so we're at least 1 million times bigger. We have the outcomes, once again, on any health system. Can we go beyond this just kind of bits of information by reframing this? And the short version of this, in terms of time, is that we can. The blue bar here is actually much more information. That's one of the clinical models. This has really more questions that I showed you in the earlier slides. It has like detailed family history of ovarian cancer and what age and which cousin, whatever. It has density. An image alone, which lets you deploy in a different way, I get 76. The map is not visible as far as I can see, but there's a global thing where we, out of the box, put into many other places, it worked. This was originally 7, but we didn't stop. So working with colleagues at MIT, now it's actually out of date now. It's at 60 hospitals that we're doing different studies. And we know that it works. It's not just a narrow, like one hospital finding. We can predict better. Now, one of the things that's interesting is now that we're treating this as a more serious competition while we're learning stuff, we can actually do better. So if you check out Michael's poster today, he's a CPH student, we have a new version of the model that's already better by 4 points across different time points. And we are still only scratching the surface because only like both Mira 1.5 are just one image. But we have so much more in this context. And I think this whole field still is infancy. One direction I think is part of the frontier to make these models better and better is tackling the kind of scaling problem. Like part of the reason we don't have these gigabyte models is because it's very hard to build them. And as the inputs get bigger, kind of basic computational building blocks break down. And so if you go to the other poster, led by Christian and Tony, you can see the architectures were built in to kind of address that kind of key challenge. All right, so hopefully by now I've convinced you we can predict things better, right? We can predict it better at the hospital we built it, so we can build it better also like all the other places where we can validate it. But that's not enough, we need to do something about it. So I want to tell you briefly about 2 ongoing translational things we're doing and the kind of challenges that raises. So one study that so kind of step back, right? We told you 2 challenges. How do you make care more effective for people who are going to get cancer? How do you reduce the harm for the rest? On the care more effective side, we're running an MRI trial. This is actually very similar to the kind of setup that Ziad was telling you, where like you have high-risk people, you have a new criteria that does not agree with the old criteria. You think you'll have a much higher PPV of cancer. We're running a trial to test exactly that. We started enrolling at UMass, and we'll start at UCSF and a couple other sites very soon. And another trial focusing the other end of the spectrum. How do we make the actual care pipeline cause less anxiety and kind of smooth that process? We're running a study at SFGH where for people who haven't gotten mammograms, usually the screening pipeline is like you get something, maybe a week later you get told, oh, come back, something's sketchy. Maybe 2 to 4 weeks later you get scheduled. So you kind of get the whole end thing within 2 to 8 weeks. One thing we're trying is in real time, this was less miserable into getting with Epic. This is much easier because there's an image. We'll get a risk assessment. Before the person leaves the room, within seconds, we can flag them, invite them for a same-day assessment. So far, at the time I made the slide, 100% people said yes. And this is a very simple low-hanging fruit to make the pipeline smoother. And patients are happy. Now, you might have caught a problem here. These are MIRI studies, but we already have MIRI 1.5. And this is a challenge I've been talking about since before this model existed. And one thing that I face a lot in the way we think about translation is that our paradigm here is totally incompatible with expecting rapid innovation. By the time the fast workflow trial is done, we'll have a better model, it's 1.5, and the results don't translate over. By the time the MRI trial is done, that requires years of follow-up, it'll probably be at OMIRI 3 or 4. And this fundamentally needs a new way to think about the way we generate evidence. And this focus will be at another poster you can check out later today, led by Wen Chen. A key idea we can kind of use in this, and this is common across many things we're thinking of using AI to allocate interventions, is that the AI model is not the intervention. Like the MRI is what catches the cancer earlier. It's not the risk model in itself. And it's like that defibrillator that actually prevents sudden cardiac death. It's not the fact you had a risk score. And this specific causal structure creates new opportunities. So the basic idea, I'll go back a slide, is that because you have different AI models that are easy to run back in time, you can figure out where the models agreed. And as long as you're willing to assume that it doesn't matter which model told you to get the MRI, that the effects on the patient will be the same, and with a couple other details, you can actually create a new kind of adaptive trial enrollment. But first you run a full trial. To give an example, this is actually the SDA trial. We enroll 100 patients, MIRA trial 1 ends. Now we have 1.5. Restarting from scratch would be incredibly expensive and create weird disincentives to actually study these things in real life. But if we actually just look back in hindsight, we actually see that 70% of the 1.5 high-risk cohort is already inside the MIRA-1 cohort. And I'm perfectly happy assuming that it doesn't really matter which risk model told you to get the same assessment. If you should have said yes, we got on the same effects. And so we could just enroll the 30 new types of patients that weren't high risk before to get back to the same kind of causal estimates. And with this kind of setup, things just get, with every new trial, the next trial gets faster. And to kind of wrap up, what if all of this works? I think we have really grand opportunities to both rethink the way we think about screening and guidelines and treatment guidelines within cancer broadly, but to make workflows better, and there's opens a lot of doors. And with that, I want to thank you for your time.
Seriously, I think we've heard three different perspectives, yet complementary, but using different types of data and moving some of the models that we're developing from discovery and kind of research into the clinical space. And I think the audience would benefit from hearing from your perspective, what were the biggest challenges that you faced in that process? And maybe some solutions. I don't know who wants to start.
I can start. I think going back to the point that you addressed around what surface physicians are going to be using to interpret that information. Like that is the hardest part of this. Like everything I showed is the easy part.
Yeah.
It's like figuring out like when I say surface, it can be basically it has to be a screen, literally like pixels, or it has to be an audible, or like there aren't many other options. So like that's the hardest part, is convincing folks to accept this new metric on a screen of some sort, and convincing that it's worthwhile. Like we can put it as a BPA or we can put it in the corner, but what we see is physicians have to change their mindset to just like start reading that and changing their workflow. And that is super hard. That takes years to change practice at an institution.
Yeah, I would add that every part of the pipeline is hard, so it's hard to choose. So I can share a little bit about the way we thought about translating the risk-based stuff. Okay. So like one type of challenge is we want to make sure the stuff actually works in practice, because the retrospective AC numbers aren't anything by themselves. You need to actually have in this workflow, how do we actually change the quality of care? And running those kind of studies has been much more challenging than I've expected, partially for it's like funding for this kind of thing is not straightforward, but also regulatory for it's not straightforward. Like even the workflow study that I showed, like the SDA thing, which is like you're just changing when someone gets screened, it's not at the highest risk thing that one can do in care, was about like 10 months of various committees reviewing the study, asking kind of similar questions and that type of thing. Like there was points I was questions like, what am I doing with my life? It's taking so long. And there's many challenges of that to even like get things out the door, and kind of like, there's healthy instincts, let's create safety. But as we add more layers of that, there's rarely an instinct of let's refactor to make so we can get studies out the door faster. Because in this, like there's many things of like, why does it take so long for a study to happen? Part of it is the intrinsic, what do we need to do rigor? You need follow-up, you need this number of patients, whatever. But there's parts of that we could remove. Even when the thing works, I think there is a challenge of like, what is a version of this that's sustainable for adoption outside of this kind of academic research setting? It needs to be profitable in its own sense and maintain its own incentives. And like, we've spent a lot of time thinking about that. And it's led to shifts in how we even think about what is the thing we're putting up. Because sometimes if you create a lot of value, but the value you're creating is narrow, it's hard to motivate a workflow change. So one thing we thought about is how to make the value creation broader across more use cases to justify having a different interface in the first place. And that is the kind of ongoing challenge I'm thinking about.
Maybe I'll just point out a different thing, which is that there's a bit of an optical illusion in the sense that anyone who's up on this panel has already done something that requires accessing data. And so conditional on that, there are many hard things that then come up. But have you tried to access data? So that is the bottleneck. Like that is, to a first approximation, it's the only thing that matters. That is by far the hardest part. And so this is something that I've been incredibly frustrated by over the years that I've been doing this work. And so I'll just highlight two things that I've worked on that might help you overcome what I think of as this very first order problem. One is a nonprofit called Nightingale Open Science. We got philanthropic money to work with hospitals and create interesting data sets of images linked to patient outcomes. So we scanned, for example, a bunch of breast biopsy images. We digitized the whole slide images. We linked that to longitudinal data from the electronic medical record on metastasis and long-term cancer outcomes. And those data are just available overnight after you sign a data use agreement. The second is it's a for-profit company called Dandelion. Dandelion has assembled a consortium of large non-academic medical centers across the country. We get their data, we de-identify it, not just the EMR data from Epic or Cerner, but also all of the electrocardiograms, the images, the inpatient monitoring, the whole slide images, that like the retinal photos, everything that they have. We de-identify that and we bring it over into our environment where we make it available to companies, but also researchers who want to build clinical AI products. And I think that I know of several startups that have burned through their entire Series A funding while they were waiting for a hospital to sign the data use agreement that everybody agreed was a good idea. And I think that all of those bureaucratic obstacles that Adam mentioned, I think are all the more binding at that earlier stage of trying to get access to data.
Yeah, I can't agree more. And I can also share a little bit of the Baker perspective on this. One of the efforts that at UCSF, and thankfully this is available to everybody in the CPH program as well, is we have a resource called Information Commons. And there are a few people in the audience, Sharat and Gundalf here, that has been pioneered by Dr. Atul Butte at UCSF, making de-identified clinical data available to researchers and bringing all sorts of resources together, including de-identified clinical notes. And there's also a lot of data available across the UC system. So you're right. We're incredibly fortunate here to have access to data. But I would say another challenge that also precedes all of this is asking the right question and figuring out which questions, which models would be useful in the clinic. And really, from my perspective as a more of a discovery researcher, that's key. I want to make sure that things that I work on and models that I develop are useful down the line. And some of those might not be. They might be interesting scientifically, but not there is a so what aspect of things, which is challenging and really requires collaboration.
Yeah. And if I can point out, there's one interaction with the data thing, which is that finding the right question is really hard. And so in that setting, of course, what we do in our PhD program is we try to teach and help people ask the right questions. But there's also there's a numbers game that you need, which is that you need a lot of people asking a lot of questions. Yeah. Many of those questions will not be good, but it's really hard to know which ones of those are which ones in advance is not. And so the worst possible situation for innovation is when you have a small, privileged group of people who all basically think in similar ways, being the only people who can ask questions. But that is a perfect description of our current system, where only people who are privileged enough to work at these institutions where the data are accessible and online those are the only people who are allowed to ask questions. And there are lots of people out there with great ideas who cannot do that. So that, I think, for me, is the biggest argument for broadening access to data, is getting a more diverse and more creative pool of people in, because that's how innovation has happened in every other industry. It hasn't been top-down small groups of people. It's been broad-based market forces that have led to innovation.
Absolutely.
I guess to add, like, I think we're in consensus that kind of every step of this pipeline is hard. This is kind of, everything is still, in a way, still a young space, and that, like, it's not like we have smoothed out the data pipeline. Once you have a model, now it's smooth. Or once you have a positive trial result, now it's smooth. It's hard along the way. And I guess say, like, what is the solution? Right now, it's just a lot of willpower and a lot of excitement of, like, because why do you build a model in the first place? I'm not building it for the paper part one. It's not just to have a data securation paper, or like, this is a trial result. If you build it for the end change, that, like, right now, willpower is the only kind of solution in the game.
And collaboration. I would
And collaboration,
say, right?
but that's because you find other people with high willpower who will fight with you to make the thing happen. Yeah. And I think in a weird way, it makes it satisfying. You do it because it's hard.
Yeah. So I guess another thought that comes to mind is, all of these models are built on data, which we know it has inherent bias. So how do you think about accounting for that in this whole process of development to deployment? I know it's a hard one.
I mean, it's something I've spent a fair amount of time working on. So maybe I'll just tell you what I've done, which is, and not to sound like a broken record, but how do you know that a model is biased when you've built it? Well, you need to apply it to data where you can see how it's doing in diverse groups of people. And you can't do that unless you have access to data. So the people who are developing models, they don't know if their models are biased because they only have access to data from the Mayo Clinic. And on the off chance that there are people you might want to use the algorithm on that don't look like people in Rochester, Minnesota, like, tough luck. Like, how do you know? So I think that audit function is really, really important. And it's currently not very well developed. And I think the FDA would love to tell people to go audit their algorithms on external data that the model hasn't seen that's diverse. But how can they? It's, like, currently very, very difficult. So it's not a reasonable ask from the FDA, which is why they don't do it. So I think the audit function is really important. And for what it's worth, when I've worked on auditing algorithms, typically for racial bias, but for a range of other distortions, we've found a lot of problems with a lot of algorithms that are deployed and out there. But all of those problems have actually been fixable. So it's very rare that we've encountered an algorithm that is just like, you have to throw out the whole thing. You need to retrain it on, a different outcome typically, and that creating that outcome requires a lot of clinical knowledge and knowledge of the workflows and understanding the data generating process. Like, what is this? What is a billing? What is an ICD code? Well, it's from a transaction between a payer and a provider. Okay, who doesn't have transactions between people who don't have insurance? Where are those people in your algorithm? So, like, there are all of these things that I think are second nature to many people in this room, but that are not at all second nature to people who are building and deploying algorithms at scale. And I think that that's really important too.
Absolutely.
Yeah, the one thing I'll add is, having partnerships. If you can be part of networks that have access to like, especially like outside of U.S. data, being part of health information exchanges or ways that you can collect data from multiple different sites. That's the best. Like, it's hard though. There's no if you need ECGs, for example, it's you got to call up every site and like make that like partnership and make that deal to say, hey, like I'm going to collect all your data. So it just takes time. Like, there's no silver bullet in collecting this data. And
sometimes like hospitals' contracts with GE or Philips doesn't allow them to get access to their own ECGs, and it's like they've bought ransomware. Like, it's the hospital can't actually access their own data from GE or Philips without buying out the contract, which I've had to do several times. I'm sure you've had to do it too. The current situation is completely insane.
I would add, in my own broken record thing, it is hard, but if you try hard enough, it is doable. Yeah. So like, my version of this, so I agree it's an evaluation problem. Like, often the case is you just don't know that there's bias, and that our regulatory pipeline is slow and laborious in its own sense, but it does not enforce this kind of thing because it feels like too big of an ask. But in my own work, like I have now many collaborations with a hospital system in Taiwan that I met via cold email. And to find them, there was many dozens of other hospitals that I reached out to, had many meetings of which a handful came out. And if you, like the way we did the original 7 hospitals was I was at the time a CSPC student, cold emailing a bunch of places. And I convinced some friends who were not involved in research, who were like worked in finance and in sales, to cold email people on my behalf to industrialize the thing. We built a little CRM. We just boiled the ocean until we found it. The way that we do now the hospital network in collaboration with MIT, it's the same thing. And it doesn't get easier. But you get better at trying hard. That's
As Adam's co-author Regina Barzilay once told me, you have to kiss a lot of frogs.
All right, maybe we'll open it up to the audience if there are questions. Yes, I think there's a mic up here. You can also project. And introduce yourself, please.
I'm Joyce in the postdoc. Well, okay, I'll speak loudly.
Awesome.
I'm Joyce in the postdoc at UCSF. I'm curious, you've all talked a lot about the challenges of extracting data from what are admittedly fairly data-rich environments. I'm curious about what your thoughts are about, how to utilize this type of technology for low and middle income countries where, these types of data sources are not even available or maybe much more sparse and even less clean and potentially not online at all. This question of right now, this sort of space being really a bunch of people with very similar viewpoints at top tier institutions in Western countries is true. And so it's not even within the US that community hospitals get these benefits. So I'm curious about your thoughts on what international.
Yeah, I think there's a huge opportunity in that problem that you very concisely pointed to, which is, so I'll give you an example of a project that I've worked on, which is with a collaborator who has a research infrastructure in southern India in Tamil Nadu. We actually got a bunch of medical equipment from hospitals and we brought them into rural villages. And we did linked retinal photos, smartphone-based ECGs, a lot of point of care testing. And we also did x-rays and cardiac ultrasounds and a bunch of stuff you can only get in the hospital. And there's now a data set that anyone here can access on Nightingale within 24 hours of all of those things linked together. And the cost of creating that data set was very low. And so even though, of course, there's not a lot of data right now, it's actually really relatively cheap to create not just the kind of routinely created data we have now with all of its problems, but actually just to create brand new data sets that actually do cool new things and that let you build algorithms onto wearables that you can deploy with community health workers in people's homes to cut the health system out of the loop entirely. So there's a lot of new things you can do because you're starting from a much earlier point that you can leapfrog over all of the dysfunctions of our current system here.
Yeah, part of our approach has been just trying to find local partners in the various places. And I think it just takes a similar level of ocean boiling as anything else. So we have one collaboration with some folks, with a couple of nonprofits that are working together in Nigeria, trying to study the breast cancer workflow. Their screening is very different. They have very different care issues, and it's very challenging to get these data sets. And for years now, we've been on regular calls trying to figure out how can we support them to do what they want to do using this technology. And I think there's no silver bullet there. There's special challenges in that, but it's the same kind of thing where it is relatively easy to find partners that really care, that are willing to try very hard with you. And it's just a matter of being committed to making it happen.
One other thing I'll add is, we've deployed our software that required an internet connection in very rural places, and it's being scrappy. We just bought a SIM card with basically a Wi-Fi adapter and just plug it into a Chromebook, right? And it worked. It worked fine. And I'm sure there are cheap ways or open source solutions to have basically Microsoft Excel be your EHR, right? And so there's ways that you can very cheaply build EHR in a box that just collects this data from devices that are local, that have no internet capabilities, and just try to create a central database that you can start, maybe not moving all the data to the cloud, but just having it at least in one spot to start.
Thank you. Maybe one more question. Go ahead.
Thanks for having me. I want to cast a ray of hope here and tell you why the CPH program is so important. We have this vision, Marina referred to it, it's called Information Commons, which has barely begun, and it's been painful over the years to make it. I hear you very clearly. But we have this vision that's going so far that it's hugely encouraging and available to the UC, at least to the entire UC system, which is quite a large population. All data at your fingertips, all the way down to the research corpus, fully linked in real time, get started within hours or days, not months, with essentially ability to build what you want at scale. Our idea of data mesh and so on is well beyond to knowledge graphs. Knowledge graphs are a construct that's essential on top of the rest of quote unquote AI. So you can do the reasoning after that, which is the third leg, which is to come. Therefore, that's where we need your way of thinking from Berkeley with us. That's why I think CPH is so important. That's our vision. And I hope that you'll help us get there.
Thanks, John.
Hi, I'm Nicole Ersaro, Program Manager of the Center for Biosignal Research at UCSF. And I was curious, the point made in the first presentation about how not needing EPIC kind of opened up a lot of maybe other ways to think about deployment. And I was curious if that's something that you thought about at the beginning, or like, okay, we don't maybe want to use this information because we know that will make more challenges. Did it not add in performance? And if that's something maybe all of you sort of think about is how can we kind of do the most with the minimal data or data that's more easy to integrate?
Thanks for asking. The images are really cool because A, they look the same no matter where you do them in the world, minor variations notwithstanding. And B, they liberate you from, the tyranny of the electronic medical record. And C, they're very rich in information that humans are not very good at using. So for all those reasons, I think images and waveforms are great. And just as a fact, if you add in even age and sex in Sweden to the waveform and then take that to Southern California or Taiwan, it does slightly worse than just using the waveform.
Interesting.
Aging doesn't work the same in different places. So why would we, just because the variable is called age doesn't mean it's the same thing. But the heart, it's still a heart.
Thank you. Awesome. Thank you so much. I think we've had a great session, and let's thank all the speakers.